Good afternoon, everybody, and a very warm welcome to this session here in Singapore. Thank you to our hosts at Seri, and thank you. We find ourselves in our final formal session here at 2030 Insight Live, and I'm very grateful to our guests for joining us here, our guests for joining us in our auditorium, and also if you're tuning in, hello to you, or if you're catching up, welcome. I'm Ollie, I'm going to be your moderator just for this next hour session. A really crucial session, this one, because this answers the question, how do eye health and organizations in the eye health sector work together in crisis situations? And this is close to the heart of many of us here, especially on our panel today. And we might find ourselves casting our mind back to crisis situations, including a pandemic, let's be honest, but also casting our mind forward to what we might expect and how we might be best prepared. So let me say thank you to our panel for joining us, led by Jerry here. Let me introduce you. Jerry Vincent is the theorist behind the Humanitarian Response Interest Group, and we'll be hearing about the group today. More than 30 years' experience working on the periphery of numerous conflict zones. Thank you, Jerry, for your energy and time on this. Next to Jerry is Natasha Yu, an optometrist. Currently advises the WHO on human resources and chairs the IAPB Climate Action Work Group. So welcome, Natasha. Next to Natasha is Tricia. Tricia Keys, also an optometrist. After a stint in Australia for UNHCR, now head of operations for Act for Peace. And that's an Australian NGO, you should know, working with displaced people. So welcome to our group, Tricia. Nice to see you. And finally, Sangshul Yoon is an ophthalmologist, an external health advisor for KOICA. That is the Korean International Cooperation Agency. And their remit has included the Turkish earthquake recovery and the Philippines typhoon recovery. Should we give an IAPB welcome to them all? Thank you very much indeed for joining us. So in the interest of getting everyone's voice in as soon as possible, perhaps a word from each of you, or more than a word, but a few words on what this topic means to you. And I might actually start with you, Natasha, if I may, please.
Thank you, and I'm very happy to be here. It's a very important topic because it really means opportunity. That's what it means to me. So it's an opportunity to right the wrong, crisis to action. I feel it's a pivotal moment that we are in right now, and we need to be transforming adversity into some positive change. Now, if I think about in the context of climate change and eye care, it's about using that pressing issue of the climate emergency to really make some meaningful changes. We can collaborate with others, we can harness that energy that we have in the room, and we can really inspire some innovative solutions so that we are getting to the root of the problem.
Yes.
But for me, it's an opportunity. That's how I see it.
And we don't really need reminding, but I think it's worth saying that we talk in big terms about a climate emergency. But what we're talking about here is the fact that the climate crisis triggers very specific emergencies. So just help us just get our heads into this with the sorts of crises that we might be dealing with, and we're going to discuss over this next hour.
So very much linked to my other panel members here, it creates displaced migrants, so the climate migrants, and it's predicted by 2050 there to be 1.2 billion migrants from the climate emergency.
Yeah, no, very vivid. Thank you. Sangshul, what does this topic mean to you?
The crisis response and eye health is one of the meaningful intersection of the integrated, people-centered eye care. That is one of the priorities of the global eye health program.
Yeah.
So, okay. And I think that this is the kind of the eye health has been neglected in a crisis response. But many people are suffering from the lack of the eye health services in a subacute and recovery phase. So if we have some of the good example and disseminated this experience, will be make a better the crisis response as well as the better future eye health program.
Yes. And your role within a coordination agency, is that, who are you coordinating between?
I'm coordinating with the partners country and our government at the level of the diplomacy,
Yeah.
but also we at the field we are coordinating all the participants from the partner country and INGOs and the volunteers from the other countries.
Yes, understood. Thank you. Tricia.
Thanks, Ollie. So for me, I guess crisis to action, it's really about using crisis as a catalyst.
Yeah.
So a catalyst for change. Often we'll be responding to an emergency, something immediately, some immediate action. But I think it's really important that we're also thinking of like the longer term role of whether it's eye health, optometry, and what we're trying to do, and really then lead that to then look towards creating some systemic change, like integrated eye care. So I guess in what my work now is we're working with displaced communities. So if displaced from disasters or conflict.
Yeah.
And so often eye health, it's not the number one priority.
Yeah.
But I think it's looking for opportunities where we can work with health systems, where we can, I guess, strengthen, broaden those collaboration and partnership opportunities.
Yeah.
Yeah.
Now, forgive me, many in the room will have been right in the centre of this themselves, but I really want to locate eye health in the context of one of these crises. So before I ask Jerry more about the group, Tricia, is there an example that you just paint as a picture of a scenario you found yourself in where eye health has had a role to play or perhaps hasn't been successfully integrated?
Yep. I'm actually going to go way back on that.
Yeah.
So in my current work, I'll be honest, yes, we're not really working much with eye health. Do have, a couple of programs, but not really. But I mean, for me personally, I think my actually entry into this sector was in crisis response. So yes, I'm an optometrist, used to work in private practice, but I actually got involved in the sector in international development through an optometrist interested in volunteering and going to, work in a crisis, responding to the tsunami back in Sri Lanka. But then we realised that, okay, that's sort of an immediate need, but let's use that to look at the longer term need, the longer term solution, the training, the integrating things into hospitals and eye care and national systems.
Yeah, fantastic. Natasha, when you hear that sort of very real, very evocative memory there, what do you draw from your memory?
Well, I was there with her, so...
Yeah, gosh.
Yep, definitely that's what drew me to optometry, drew me into the eye health sector, and it really opened another world of public health within eye care.
But help us a little, just momentarily, to capture this, because there's been a terrible disaster. You rock up, you're keen to help, you don't want to be unhelpful. How does one even begin to engage with the enormity of what's happened there?
Yeah, so I think it was a very in-your-face realization that when we got there, they didn't have the basics, and we were coming here with glasses. So I think there's a balance that's needed, and there's appropriate timings of everything. So that's something that when you collaborate with others and work with diverse stakeholders, that's what you can get that balance right.
Yeah, and I'd love to get some of those reflections going as well. Jerry, going back to the big picture on this topic as an overview, something you've thought an awful lot about.
Yeah, well, for the past 30 years, I've kind of worked in this little bubble where eye services overlap with humanitarian health. And it was really lonely. I have a lot of good colleagues and friends in the eye sector and a lot of good colleagues and friends in the humanitarian health sector, but there are two different worlds and there wasn't a lot of overlap there. So I'm really happy to see everybody here now interested in this topic. It's more than time that we bring this up within the eye sector as something that all agencies need to have some awareness of and some knowledge and skill in applying going forward. So,
and I want to talk about the group. Before we do, with no sense of blame attached, why wasn't there an overlap? What was the missing link? What was the block?
I think people don't realize how difficult, sparse, and stark a real response can be. And the onset part is about saving lives. Yeah. And if you come too early, you're actually hindering that. So you may intend to do something good, but you're actually part of the problem. So there's a way to engage, and you ask, well, how do you know when to do that? And we'll talk about that with the humanitarian interest group.
Yeah.
So, yeah, it's something like that.
Well, let's start to unpack that a little bit. Tell us a little bit about the group, its origin, but also what its mission will be.
Okay, this is an IPB interest group, which may become a working group for humanitarian response. It's brand new. There's been one meeting by Zoom, so not a lot of people participating yet. If you are interested in participating, everybody is welcome. We would like to have some representation from all the different agencies. You can contact Brooke Blanchard by email or myself. We'll make sure you get on the list. And you do not even have to be IEPB or even the I sector. You can still belong to this group. Now, the group is brand new and trying to find a little bit of a sense of direction. The TOR for the group is not formalized yet, but once that is, we'll publish that on the IPB website. There will be tools and guidance. In fact, some of the tools and guidance are predating a little bit the working group and are done through the SEVA Foundation, but we will get substantial review and input by the working group to make sure everybody has a chance to collaborate and provide some input, and there'll be substantial input on the humanitarian health side as well. On the I side, we have IPB, we have WHO, and a lot of international advice and guidance.
Yeah.
On the humanitarian health side, you have that as well. So we need to kind of combine all this, explain how it works, and then float that around so that people can read and make sure they understand and clear about that. So that's the bit there. The other thing is the humanitarian sector really is a specialty. It's a discipline. You can get graduate degrees in this, and when humanitarian responses take place, there are a lot of actions that take place with a lot of groups like we have in IEPB, but that do very specifically humanitarian work. There are UN agencies like we have WHO for iCare that help oversee that, and you have to work with the local government. But the mechanisms are very unique for these contexts that are not necessarily intuitive.
Yes, understood.
So we need to also, we spend a lot of time in iCare building capacity of our partners. We need to build our capacity so that we know how to engage in that field or sector. And so part of this will be tools and guidance. Part of this will be trying to find ways to build the capacity of the I sector. Some people may feel that, well, our agency isn't interested in this sort of thing. And I've got news for you. It doesn't matter. Things are going to start landing on all of our heads. So we need to be able to know when and how to respond, even if you don't intend to travel anywhere in your catchment areas. So.
Would you mind, Jerry, just give us a few more examples of when a crisis hits, how that impacts colleagues in the sector? I mean, we've had a couple of hints, but I just want to get a sense of the breadth, because there might be examples that aren't as obvious.
Right. Well, a response to an earthquake will look very different to a response to a flood, which will look very different to a response to a refugee crisis. And that will look very different to a global pandemic. However, the way the humanitarian sector responds uses the same, it looks different, but it's the same processes, the same thought patterns, the same prioritization, the same mechanisms, even though they're tailored to very, very, very different contexts in very different countries. It makes sense once you understand kind of how the system works. So that can all look very different. In terms of iCare, these different contexts do make a difference in how we respond. And some of that's a little bit counterintuitive. Something like an earthquake where you have a large loss of life and a lot of injuries really don't do much to eyes. However, they destroy the eye health system. So there's some rehabilitation that needs to be done to the eye health system.
Yes, understood.
We all experienced the pandemic, and some of these crises, including the pandemic, just disrupt the ability to access the system.
Yeah, exactly.
So we have a lot of lessons there.
Yeah, excellent. Thank you, Jerry. Natasha, let's dive into this link between eye health and the climate crisis. Just help us draw those links more strongly.
Yes, so if you weren't at the previous session, which was about climate change and eye care, and just to acknowledge the great presentation this morning from Professor Mahmood.
Yes, Jamila, brilliant.
She definitely laid it out very nicely. But just to go in a little bit more detail, so we can see the link in two ways. The first way being is how climate change is impacting on eye health. And, we know that it impacts health. We know it's through the climate change events. You can have injury, mortalities, you can have respiratory issues, heat-related illnesses. But then when you draw it down to the eye health, You're looking at things like poor water supply. It can lead to increased risk of ocular infections,
Yes.
such as trachoma. Then you have your air pollution that kills up more than 7 million people a year, but that's also related to allergic eye disease,
Yes.
dry eye disease, macular degeneration, glaucoma, diabetes. And then you have your disruption of eye care services, which Vincent pointed out.
Yeah.
That basically we saw in the pandemic, eye health gets deprioritized, and we basically have a big backlog of all these cataract surgeries, spectacles that need to be supplied.
Yes.
So that's sort of the negative impact.
Yeah. And in your experience, how confident are you that the organisations that you're seeing are working through, wargaming is not the right word for it, but planning what would happen should a crisis hit?
Yes, so that's the other way. So we need to be building resilience.
Yeah.
And I can't say that we're there yet. Certainly there are leaders in the sector that are doing this quite well.
Can I ask you to name and fame? Does anyone come to mind that does it well?
Yes, definitely Aravind Eye Care Hospital.
Yeah.
They're leading the sector in this. We use them as a great resource to share case studies of how we can be doing things. We're developing guidelines and toolkits from the case examples they give. But there is a lot needs to be done.
Yeah.
WHO has some great resources out there about building resilience in your health systems, looking at how vulnerable your system is and doing an assessment on that, and then building that resilience.
Yeah, and just briefly on that question, Tricia, just on that line of shining a light on those doing it well, not so much reflecting on what's been, but modelling through what could be. Any examples that we could be inspired by?
Sure. So I guess in my work now, we're working with communities that have been displaced.
Yeah.
So where that's conflict or disasters. And I think, so all our work is through local partners. And I'm sure there's more out there, but I guess there are a couple of examples that I am aware of. So I'm aware that Fred Hollow's foundation was working with the refugees in the Rohingya, in the camps there. So in Cox's Bazar. So there was a lack of eye care services. So increasing the capacity, doing more cataract surgeries. Because I guess that's communities that they're already vulnerable.
Yes.
Well, I mean, we know ourselves, eye care, in the eye care sector, that importance of vision, eye health, importance for livelihoods, general well-being. So you add that, combine that nexus, the people that are already now severely disadvantaged.
Yes.
The most vulnerable already. And then I guess, restoring the vision is then going to improve their livelihoods as well. So that there's an example there.
Yeah.
One of our partners in Gaza, in Palestine and Gaza, that does health clinics. So I know they're receiving some funding from Fed Hollows to do eye screenings.
Yes.
In the clinics, in the community.
No, these good examples. Thank you, Tricia. Let me say to our guests here, we're looking for your questions, so please start to think, and particularly if this isn't your sort of home territory, so to speak, in terms of crisis response, no such thing as a silly question here. So what's on your mind that hasn't been clear or needs some extra attention, please let us know. I've got some specific questions, though, just briefly. Sangshul, if we turn our mind back, we talk about, in a very hopeful sense, about being post-pandemic. And yet, for many, we could still be pre the next pandemic. So can I ask you to reflect on how you responded during the COVID-19 pandemic?
Okay. Actually now we are entered the recovery or the endemic phase of the COVID-19 pandemic, and many countries in my work need to build the new disease surveillance system. If they have a somewhat weak health system.
Like an early warning.
Yeah. So the main component of the digital surveillance system is the kind of a sentinel surveillance system with the lab information system and monitoring the lab performance. In addition, sewage surveillance system and the periodic monitoring of major non-communicable diseases such as hypertension and diabetes and its complication. And my work maybe I add some of the ophthalmic sentinel surveillance system, not because I'm an ophthalmologist, I know my due diligence very well, but it is very meaningful because in Korea we experienced around, it was 2002 and 2003, there's two huge epidemic of conjunctivitis. Yeah. That outbreak covered over 2,000 schools, and many of the high schools had to be closed.
Yes.
So after that, we designated 85 up to 90 eye hospital and clinics to set up the sentinel surveillance system, and they report automatically the trend of the conjunctivitis confirmed cases on a weekly basis.
Yeah, so this outbreak of conjunctivitis sort of sparked you into action to become better prepared.
So it is kind of the additional tool for the surveillance, but in the COVID-19 situation, it also can be useful to detect early detection of the COVID-19 because the COVID-19 has also eye symptoms. Yeah. So we can formulate it into the one system with every kind of sentinel program, so that we can depend very well at the beginning of the COVID-19. And also we wanna put this similar system with at no additional cost.
And is there an example of something you now have in place because of what happened in the pandemic that rather than being temporary is now a permanent change to the system, but particularly in eye health?
Because everyone recognized that kind of the monitoring system is very important, and also diagnosis and performance, the quality care. Yeah. Both of things are the very important for the robust health system, as well as we are talking a lot of the health resilience. So we have some of the enough capacity to deal with the additional outbreak and the crisis from any other reason that can be not only the kind of the infectious disease, but also all of the health sectors combining together in one system.
Yes, no, interesting. Okay, so let's pause there to look out for questions, observations. I see in the front row, 1, 2, 3, and with a bit of help, Russell, why don't we go to the back first, and then we'll just go down in order. That's great. If you wouldn't mind saying where you're from. Thank you.
Thanks very much, panelists. My name is Laura. I'm from the Fred Hollows Foundation, but from the business development and partnerships front. So most of the eye health organizations here focus on health system strengthening, working alongside national governments and ministries of health and so forth. Now, for most countries, at least in the Asian region, the issue of asylum seekers, refugees, and displaced persons is considered a fraught or at least a sensitive topic. How can those working in the eye health sector leverage their government relations, both to further the cause and the protection of refugees and people faced by crises, but at the same time protect their own relationships with government, given that you're development organizations?
That is a great question. Thank you very much. Why don't we just take one more, then I know we've got a third. I'm looking out for other requests, but there was one in the middle of the auditorium. Yes, thank you. Here we are. Does anyone want to go on that refugee question?
Thank you, panelists. My name is Hadi from Direct Aid Organization, and I represent our International Relations Office. My question is, when should emergency response trump, or what should trump the other side, if we're talking about emergency response or development, since Direct Aid does both? If we're talking about development, for example, in the eyesight or eye health, we're talking about rehabilitation, we're talking about providing necessities and wants instead of needs. But when we're talking about emergency response, there is something happening. So when
so just so I understand, and forgive me, the panelists may have cottoned onto it quicker than I have, but from whose perspective are you asking the question?
When I'm talking about the organization's perspective. So when we're
from a funder's perspective, from
an implementer, we implement our projects basically. And when we're implementing projects, when should we focus more on emergency, or when should we focus less on development, or what should get the most majority of our focus? Thank you.
Okay, understood. So two massive questions there. I'm going to open it on request rather than pick on anyone, but please, I'll take offers. Yes, please.
Okay. As to working from the standpoint of government and then trying to work with or access refugees, that will be very different country to country. National government always has sovereignty, but in the case of a refugee crisis, the national government will often request that UNHCR take care of that specific group of people because they don't have the budget, they don't have the manpower. UNHCR does this as their specialty, any number of reasons. In some cases, the relationship between the host government and UNHCR will be very fine, and in fact, it'd be easy to tap into the national health system. In other places, it's completely independent systems, and there's not a lot of going back and forth. So this will really depend upon the context. It'll be very different from one country to the next. You can't give a blanket statement that will sort of cover the world or even the region. But you are right, most governments, not just in this part of the world, most governments are very sensitive to the issue of refugees.
Right, and if I can push you on an example there, Jerry, on a scale of sort of chaotic to well-coordinated, where have you seen that system at its best? Is there a point to which you might say we need more of that coordinated response?
I don't want to say where it's bad.
No, I
'Cause have to
understand.
make-
That's why I'm going to the other side.
Yeah, okay. I actually find Ethiopia quite good, and part of the reason is the Ethiopia government has invited UNHCR in to let them do their thing, but the Ethiopian government has also said, you can come in, but you must help us develop our capacity. So the Ethiopian government is the main, what often NGOs do, it's the Ethiopian government, they have a special branch, UNHCR is paying for them, training them, so a lot of the basic health care is actually provided by a special branch of the Ethiopian government. So there's a really good sort of working relationship there.
Yeah, okay. And on refugees, would anyone else like to contribute? That was very helpful, Jerry. Thank you. Tricia.
I think, great points there, Jerry. And I think that's really important. The key is to also work, if you're going to be working in these systems, is to strengthen that local capacity. Work with the local actors, the local NGOs, because part of this is, if we're thinking back to the topic of crisis to action, is that we want to lead to sustainable change.
Yes.
Yes, we might be responding to a crisis, but we want to improve the systems and the capacity for the longer term.
Yes.
So not just sort of the fly in, fly out. Let's work with the system to improve it.
Yeah. And I suppose that tempts me to ask, where are we being unhelpful with the benefit of hindsight, either because we got our timing or our offer or our intervention? I mean, it would require some candor to talk about that, but would you be prepared?
Yes, we have lots of lessons that we've learned through the ways.
Go.
And definitely when we don't take talk to the people on the ground, see what's actually needed, we're not collaborating, we're not getting the diverse stakeholders involved, that can all lead to a bit of a crisis in itself.
But forgivable under pressure.
It is, but it's becoming more unhelpful.
So, okay. So how would you, with the benefit of hindsight, what's a real example of how you would have coordinated differently, I suppose?
So you need to find your leaders in the area. Of course, you can't speak to everyone, but you need to identify those key stakeholders that you need to talk to and ask what's really needed, how can we be helpful, not sort of a top-down approach. This is what we think you need, and this is what you're going to get. That's not going to fly with anyone.
I mean, let's stay on that briefly, Jerry. Where do we get it wrong? What lessons must we learn?
Okay, for me, the big one is a humanitarian emergency response is one element of a continuum, and it's actually a cycle. A big event happens, the first part is the emergency. That's saving lives. We do not do eye care there. It tends to be really difficult to get around, and people who have good intentions that want to be doing this or that actually get in the way and hinder. That's measured by mortality rates. If people are dying unnecessarily, that's the concentrated effort, is to get that down.
Yes, understood.
In addition to that, if you've got a new population, for example, refugees, maybe they're not dying unnecessarily, but until you get in water and latrines and get immunizations done and have a basic health system set up, everything else is getting in the way. And if you don't do that quickly, we're often experience outbreaks of cholera,
Yeah.
measles, that sort of thing, and in some cases may kill thousands or tens of thousands of people quickly. So eye care just doesn't fall into that. There's there's only, I think, 2 circumstances where in an emergency, eye care needs are there at the beginning. Otherwise, you just stay out of the way until that part is cleared.
Okay, Sangshul?
I'd like to make echoing with Jerry's answer, but I'd like to deliver the more specific case story from the Japanese earthquake in 2011. So we cannot set a very specific timing and the scope of work in general, but that was the earthquake with the tsunami, and if we recognize that the crisis past the acute phases, maybe eye health very need, because I also mention again that it is not a concern of the ophthalmologist, because just after the acute phase, the people in a shelter waiting for their rejoining their normal life.
Yes.
And during the long waiting time, there is plenty of time spending watching TV and reading newspaper. And the best asset in a shelter is the ability, the capability to get the new information.
Yes.
So if there is some person who cannot read properly, there's a person who cannot see appropriately.
And be informed.
Yeah. So that is the big issue.
Yeah.
And another issue in Japan, in the crisis situation, the cornea ulcer prevalence very high due to the contact lens usage.
Yeah.
Because no one informed them, because that situation is very dangerous
Yes.
when they using the contact lens. So the cornea is more than 10 times the normal prevalence, and it's very easy to lead to blindness because they do not
very
get the
dangerous, I
proper
understand, with the contact
treatment.
lens.
So that is another condition. So in our acute page, we have to announce to not use the contact lens if they do not have a disposable or one day.
Yeah, so like public information, really. How happy are we that we've given our guest halfway up enough feedback on this decision between development versus emergency response? Did anyone want to add anything on that? I think we were getting there, essentially. You happy?
I can just add a few more points. That immediate response is still needed to some extent.
Yeah.
We can't just say we all should be thinking about the long-term systemic change. We still have people there that need glasses right now, that need cataract surgeries right now. So there needs to be a balance between the two. But it shouldn't be we just do one or the other, I think. That's
Yeah, fair enough. Okay, let's get another question, and then I've got some specific ones. Please, right in the front row. Great.
Thanks, Ollie. Amanda from IPB, Western Pacific, and the Fred Hollows Foundation. So to Jerry's point about this is one part of the cycle, the crisis, and really thinking about your working group and what you're establishing. And obviously there are things that you can put in place, potential partnerships that you can have developed before a crisis happens. And I'm wondering from you how much of that is going to be built into it, so that preparedness for, so helping agencies be prepared. And then I guess following on from that, when something becomes a very long-term situation, so I guess to Tricia, you know, thinking about Cox's Bazar, you know, displaced people that have lived their whole life in these areas. When do you start? And I guess it's to this gentleman's point as well, something that's going from a crisis into a more permanent situation, and what is our role there? And if I can keep going, Ollie, quickly, and I'm wondering with Sanchul, because knowing that you work with Koika and you have a health financing background, has there been any work done, and do governments actually look at, if we put in preparedness, resilience building from a financing perspective or a cost-benefit analysis perspective, it's actually I guess more cost-effective to prepare for something and you're never going to prevent these natural disasters, but be more prepared rather than be spending so much money, particularly donor countries like Korea or Japan in this region. So just wondering about that. And if we get time, I'm interested in the flip side from Professor Mahmood's presentation, where the healthcare sector, if it was a country, was the 5th biggest contributor to climate change. What does that mean for eye health? How are we approaching that?
Amanda,
Sorry,
that was a barrage
sorry,
of good
sorry,
questions.
Ollie.
No, excellent, thank you. Jerry first, but others feel free to chime in, and then I must go to you.
This is
Sanchal.
about the cycle. Right, okay. The emergency response, now that may be over quickly in some context, it may drag on even for a few months in others. It is appropriate, if the resources are there and you know how to fit into the system well, to have some eye care after that point. You don't go from emergency to normalcy like that. There's a transition we call rehabilitation, reconstruction, and so on. So there's that. Now, if this is a natural disaster, it's mostly about destruction of the system and rebuilding that capacity. If it's something like a refugee crisis, you're often having to design and create a separate system outside of government that takes into account these things, and then it's fitting it into the primary healthcare system. And we have a phase in there that's maintenance, where it's not normalcy, these people are in camps, but you maintain the health at an acceptable level, and you try to keep that health maintained at that acceptable level. So there's some phases there. Comes back around when everything is done and you're back to normal, for lack of better words. You need to spend your time doing what you can to mitigate what may be the next disaster, learning lessons from the previous disaster. If there's any sort of preparations or even prevention, which is usually not the case, working on that. And in that regard, I see this working group as a very close ally with the climate group. So.
Yeah, okay. And then Tricia, I don't know if you want to come in on this, but let's go to you, and then Sanchal on that financing point.
I'm actually going to make a comment on the preparedness as well. So a lot of our work in the Pacific, so the Pacific Islands, a lot of cyclones, so communities are devastated by cyclones. So some of the work that we're doing is trying to prepare communities, build their resilience. And so some of that is setting up evacuation centres, talking to families and households around, well, what do you need? Get a little kit, your little evacuation kit ready. And so just, last week, discussion with some of my colleagues, because I was going to be, on this session, and is that it's never come up before that, okay, we think about what we need to tell people to put in these kits. You need some tinned food, you need some purification water tablets, for example. But what about people who have vision impaired, wear really strong glasses, maybe have that spare pair of glasses, or in the evacuation centres, have some ready-made specs on hand to help people who might lose or break their glasses. So I think there's some small things that we can do as well. And I mean, this sector, we can help advise health sector, advise local partners, local NGOs around some of those things as well.
Yeah, really great examples. Thank you. Sanchal, on this business case, if you like.
Actually, I can answer not the business perspective, but also kind of the official development assistance perspective. And health financing and the decision makers, it is the always difficult to follow in logical way, because they are not very logical way to decide something. But in this case, the health financing in our crisis support, including the eye health and other the integrated system, maybe my answer is not perfect the way to support the real situation. However, we learn a lot from the previous experience. Compared to the 10 years ago, the Turkey earthquake is much better the financial supporting system, because the 10 years, around 5 or 6 years ago, the Philippine cases, we just gathered the funding in our acute pages, and we are the experts were support from the executing the funding. Even in the unnecessary things will happen. But nowadays we know how to pull the funding and how to release the fund and the allocate the based on the need and time. So that is another lesson learned from the previous experience.
Yes, no, thank you. I mean, Jerry, just going back without sounding, inflammatory, how confident are you that the world is prepared for an eye-related pandemic?
A pandemic where there's eye symptoms?
Yes.
Okay. Most Ebola, everything, often has conjunctivitis
Yes.
as a symptom.
Yes.
And it's so common in all of these fevers and epidemics that you really can't use it as a diagnostic sign because sometimes it's there, sometimes it's not, and it always happens in these things. So we have to be really, really careful. You know, if you start seeing red eyes and there's an Ebola outbreak in town, this is a fatal sort of thing. And it was there with COVID, it's there with MARS and SARS and H1N1 and everything else. So you can't really use that as a hallmark that helps diagnose anything. You just have to be really careful with your in-office infection control. And if you know that this is something really fatal, then you have to question, are you even able to accept people coming in like that? So I think that's the best answer I can give.
Yeah, okay. So what about an example where in a crisis there isn't necessarily a direct role for eye health colleagues, but they know that they ought to be working with somebody? How do you end up directing them?
If there's not a direct role for them and they want to support some of the general health going on and they want to contribute, or they can, in some cases, if they're in country, they can provide help with vehicles and staff and that sort of thing on general health care, that's fine. If there's not a role in the site for eye care, then there's really not too much you can do. You're better off kind of preparing for yourself and your own catchment area and that sort of thing. So.
Yeah. And Tricia, have you ever come up with a scenario where someone reflects that actually including eye health in their programming and advocacy almost adds a further burden that they maybe could do without? Have you had a sort of sense of a pushback there, or is it always welcome?
I think probably burden is quite a strong word there. Certainly it would create a challenge, yes, and I think as Jerry has flagged and highlighted, when we're responding to these emergencies, vision, eye health, eye care is not going to be front and centre. Saving lives is in the emergency response. But I think there is that role to play in the longer term programming for the protracted crises. But I mean, at the moment, I don't think it probably has a bigger role to play than it currently is.
Yeah. Okay. Questions, observations? Yes. How about just so with your help? Thank you. Just in this front row here. Thank you very much. And I'm looking for other observations. What have we not touched on that we could have done or should have done? Sir.
I think this is a very pertinent topic for this particular IAPB meeting. So my question, using Rohingya Muslims and the Cox's Bazar as a case study, if one wants to treat it that sterilely, but I think many of the eye health NGOs have all gone and tried to do something, and I'm sure there's been a lot of good stuff done. But given the timing, given the need to integrate appropriately with the timing and all the other local actors, as an IAPB, how might we potentially help coordinate our support rather than a lot of different people all coming in, flying in? I think they got to the point where local ministries were not prepared to have any more NGOs come and visit because there were just too many, I think, offering to help. Obviously, NGOs want to help. They also want to be seen to be there as well. So there's all of those factors that one has to think about, and how could we possibly support by coordinating better?
Yeah. And you mean coordinating across the piece and or for a specific crisis?
Yeah, I mean, supposing there's another one tomorrow, how might we coordinate ourselves, not just to go in at the right time, but also stop. Yeah. You don't really want 10, 20 eye health NGOs suddenly charging in, driving in with the Land Rover.
So Jerry will come in on that, but that's such a good question that if there's another answer and others,
Okay.
if there's another answer to that question in the room, then we'll take that as well, because it's good to get other perspectives. But Jerry.
I wanted to answer this because this is exactly what we're doing. Now, for those of you who don't know, Rohingya refugees, there's approximately 1 million refugees. There's 300,000 to 400,000 locally affected people who have to also be given services for free because their livelihoods have been destroyed. So that's a huge population. to answer your question about having a lot of people sort of come in, it's not really appropriate for an agency to go to another country to respond to these sort of things. You need to have competency with eyes, ideally competencies with humanitarian work, but also competencies with the local context. Yeah. So the people who are responding in Cox's Bazar are the agencies who already had a presence in Bangladesh. Fred Hollows, Orbis, Sightsavers had given some money up front. CBM is supporting a group. SAVE is providing technical support, and that's what I do. We're really watching this carefully. One, it's the largest response we've ever done. Secondly, it's the first time we've had multiple IAPB agencies trying to work together. Now, that's a little harder than it seems, but because of that synergy, IAPB is involved. We've done a RAB survey. We just completed a RARE survey. There'll be a strategic plan for that district, not just for the refugees going forward, and we will probably try to put together a joint appeal where all agencies are involved to cover everything in one big proposal to try to see how that goes. We're documenting this, we're watching this, because there's a lot of lessons to be learned here. Yeah. In bigger responses in the future, we will need to do this as a group, not as a bunch of individual agencies.
Yeah. Thank you, Jerry. Your takes on this welcome, even if you're not intimately familiar with working with IAPB, because your perspective really valued. Natasha?
So in terms of coordinating efforts, I think that's across whether it's emergency response or a long-term response. We have prevention of blindness groups for this very reason. We had lots of NGOs. We have experience doing that in countries where someone comes the next week. Oh, we just had someone come here last week with these glasses. Yeah. So definitely needs to be coordinated approach. And if you're going to be going somewhere, you need to be transparent as an organization, I think, also about your programs, what you're doing, and sharing that with the relevant stakeholders in the country.
Yeah, great point. So just on this response, any other idea or encouragement? Are you building on this, Sarah? Are you going a fresh question? Yes, gentleman just next to you, just there. I hope are you coming in on this subject?
I have a question.
Great, we'll come to your next, we'll unless we've got any other thoughts on that. Please, sir, your fresh question.
So, Oli, I think first I wanted to thank you, for energizing the room for 2 days, I think, before I get a chance. And you've been marvelous.
Thank you, you're kind.
Your name is easy for me to remember because the Prime Minister of Nepal is also Oli.
Oh, there you go.
Yes. My question is, beyond the crisis, I'm Chundak Tenzing from Seva Foundation, beyond the crisis, after the cameras are gone, all the headlights are gone, those communities which are unfortunately have been victimized, marginalized, brutalized, have had lots of unfortunate calamities. Are they then forgotten or are they remembered?
Yeah.
Does WHO or IAPB put them on a priority list? Because the needs are so great. We cannot reach everywhere. Do they come up in the list? Yeah. That is my question. Thank you.
Yeah. Really good question from an obviously very wise delegate there. Thank you very much indeed. So that is a serious question, Tricia, actually, isn't it? That idea of that caravan moving on and then getting forgotten.
That's right. And I think if we need to remember people, we need to use these emergencies to catalyse that change. Use them to generate funds. It gets the public behind us to generate that support, and we all know that the financial resources are important. So if we can use that as a catalyst for the initial emergency and the longer term, hopefully they're not forgotten. I know they are. But I think that's also another example. I mean, it keeps coming up during the last couple of days about broadening our partnerships, working outside the eye care sector with other actors. So I think, yeah, we all need to work together and broaden those networks for that longer term change and the ongoing support.
Yeah, Natasha, how does that resonate with you, what our guest has just said about that idea of moving on forgotten?
Yeah, I mean, that's very much what we see with climate refugees that's happening. Yeah. They're not actually legally recognised as refugees in a lot of countries. And also the issue around climate change is that a lot of these things are actually long term. You're not going to see, you have these emergency disasters, earthquakes and things, but you have the slow rise in temperatures, slow rise in sea levels, which is targeting marginalised populations.
Yeah.
And people that work outdoors, people that work on the fields, they feel the heat more.
Yeah.
So how are we going to be approaching this? So that's where the long-term strategy, systemic change, building learning culture from each other, those things will have to come into play.
Yeah. Question from one of our guests tuning in online. Sushweta Guhade asks, great question about backlog. How to mitigate and buckle up, great phrase, to start addressing the huge backlog that has developed during the COVID pandemic, along with moving forward to achieve the ambitious global eye targets by 2030. Can panelists shed some light on this, which can be implemented practically? These are presumably millions of people who didn't get their eyes tested and so on. Any thoughts on addressing that backlog? Sangshul?
Unfortunately, that kind of a backlog happened not only eye health, but also the many health sectors.
Of course.
So the many cancer patients were over threatened
Yes.
by the disrupting the services.
Yeah.
And the non-communicable disease is much more severe. And the other marginated people who are suffering from the neglected tropical disease, they didn't get any health service the last over 3 years.
Yes.
So that is the backlog problem is that happen in eye sector. But we are returning to the in eye health program. Maybe we are trying to provide the health service, and we may reallocate the prioritization of the health services with the limited resources. But most important thing is I also recognize we did too much put our resources into the COVID-19,
Yeah.
but we neglected the other bad negative health outcome
Yes.
for disrupting the essential
Yeah.
and elective services. So I read one of the article from the JAMA. The elective is not the meaning of the easy cancer. So elective means one of the essential and routine service. So we must memorize that one. And if we, I hope not, but if we meet another health challenges, we must memorize the minimum allocation for the essential service continuously.
Mm-hmm. Just make it in place, continuously in that sense. Natasha, very briefly.
Yeah, just briefly, I just want to say when we're trying to address backlog, we need to be thinking of it in a sustainable way as well. So things like telemedicine, teleophthalmology, bringing services to the primary level, these are the more sustainable ways of really addressing that immediate need of backlog.
Very helpful. So the messages that I've taken, we just heard in our sort of final moments together for this session, is around awareness. Awareness of what could happen, the facts on the ground, of preparedness. These examples of your grab bag containing things that I wouldn't have thought to put in a grab bag before today, but thank you. And we see this in flood preparedness in the UK a lot, what goes into these scenarios, but also coordination as well. So if you were to send out just a final brief thought from each of you as to how the IAPB could help the sector contribute in a more coordinated, prepared, informed way to crisis response. A final thought, Tricia, what would your word of encouragement be or advice?
I think it's also reaching outside the IAPB sector.
Yeah.
So looking for those other peak bodies, the organisations that are, that their primary work is humanitarian responses. So how can we partner with them? Let's look for opportunities there as well.
And not wait till the crisis hitting
But
to start talking.
Plan it, develop those partnerships,
Yeah.
work through how you can work together in advance.
Thank you. And sharing with Sangshul, please, a final advice or recommendation?
Think about the integration and people-centered service. If we are thinking from the people-centered, maybe we can make many good solutions in a new challenge.
Yes, well, thank you for your coordination on that. Thank you. Natasha?
It's just to keep the conversation going. Climate change and eye care, the link is very new to some of us.
Yes.
And, there's this, IAPB has some guidelines out there with the 10 key action areas. We need to be talking about this and implementing this in our workspaces.
Yeah, really helpful. Thank you for being here today for that. Jerry, well, thank you for your sort of ongoing service in this and driving that group forward. Feel free to add another reminder if anyone's just sort of tuned in on the group itself, but also your final thought.
Okay, I think there's so many things I could say, but just to kind of really summarize this, there's a lot of misconceptions about what these urgencies are. They're not acute emergencies for eyes. We don't have to rush there right away. This is not a sprint. This is a marathon. Mm-hmm. And it's really costly. And to answer one of the questions from before, we have refugee camps that have been there 70 years in the Middle East. We have refugee camps that have been there 40 years in Africa and in Thailand. The Rohingya will probably be there 20 years or more. I don't think people realize how long this is and how difficult it is to get money. As it goes on and on and on, it's governments who have to put the money up for this. Yeah. The Rohingya's food rations have just been cut because the money's drying up. So, I mean, these are really hard, chronic problems. And we can not be aware of them, mm-hmm. but it's going to get a lot worse.
Yes.
So we have to be aware of this now. We have to start getting ready.
Okay, thank you. And Jerry, if I'm sitting in the audience or tuning in, catching up, and I say, I need to find out more about the working group or the interest group, my next step is?
Contacting Brooke Blanchard at IAPB or myself. Get on the mailing list. We'll have another call. We will be going over terms of reference. You'll have a chance to provide input. We're going to start offering awareness, raising education things. We'll have tools and guidelines coming as well, and they'll be very consensually driven and derived. So.
Yeah. No, well, thank you for that. Can I say thank you, Jerry, Natasha, Tricia, and Sankshul, very much indeed. Really fascinating session. Thank you very much indeed. Thank you.